Hey everyone, how are you all? Good. So, welcome to First Aid AMC MCQ free 2 week sessions. I hope you guys got the schedule of these free sessions, and we already had one trial class just few days ago where we discussed about the AMC MCQ introduction, and I tried my best to give you an idea how AMC MCQ works, what what you should start preparation with, and what are the resources that we should go through. But I'm sure a lot of confusion is still there, right? So tonight's session is about understanding AMC MCQ questions, the pattern of questions, what kind of questions come in exam, and how to break the patterns, how to get into the right answer. That's what we're going to learn tonight. All right. So if you guys have any questions, please write it in the chat box. And also at the end of the class, we will allow you to unmute yourself and ask any questions regarding today's session or any other queries regarding the course that we just started. You already know that this is part of the course, which means that the candidates who are already course student for this new batch that we started in August, they are also getting the same class like you. We always allow these free 2 week sessions for everyone. One, for everyone to know how we take our sessions so that you can make a informed decision whether this is going to help you or not. And also, this helps a lot of students all across the world to understand AMC MCQ. So that's what we really want to achieve from this 2 week session. Okay. The volume should not be a problem. Is everyone able to hear me fine? Famia, if you are not hearing me, maybe your volume is low. I believe my one should be fine. Is everyone able to hear me fine? Yeah, I think so. Okay. Yeah, if anyone having trouble to hear me, especially if you find out that the audio is low, then please try to check your computer or device, see if it is somehow your audio speaker is low, or even try removing your headphone because sometimes the headphone might be a bit of a trouble. So try a few things. I'm sure you should be able to work it out. So going back to what we started. So in AMC MCQ preparation, there are two parts that we always say that you need to have a good knowledge on theory, and also you need to know how to solve MCQs. Because at the end of the day, it is all about MCQs, right? Because you are preparing for part one, which is 150 MCQs in the exam. So you should know how to crack the questions in exam. In exam, there is always two things. One, that the person or examiner who is preparing these questions, definitely it's a human being, and when they prepare a question, they always try to give you some tips. There are always some tips in the question to come to the right answer. And a lot of time there will be traps. So the traps are also created by that examiner who has created the question. And the traps are there so that you choose the wrong answer. So finding out the tips to come to the right answer and also knowing what can be the trap, that is how we crack these MCQs. So tonight my tonight class is basically about finding those out, understanding how MCQ works, and then in our next class we will start in full rhythm with theory session, and we will start with the cardiology in the next class. Okay. I hope that you will enjoy the session. The session will be a bit difficult for many of you, especially if you are a beginner, but please try to cruise along with me, and I'll try my best to make sure that you understand it And also today, it's not about memorizing the recalls. It's not about memorizing the questions. Remember one thing from day one, that you will come in contact with lots of questions, lots of past recalls over your preparation time. But it's never ever a case of memorizing the answers of the questions. You do not memorize them, because all you do is understand what kind of questions are coming in exam and how we are coming to the answer, and knowing each and everything about that particular topic. That's how you prepare. A lot of students, what they do, they go into a Q bank, they start memorizing the answers, they do a lot of recalls, they start memorizing the recalls answer. But at the end of the day, in exam, the recalls are not questions that's just going to come in exam and you'll be able to pass the exam without having a proper knowledge on that particular topic. Because question will be changed in the exam, the topics might remain same, but there will always be some changes. So when we are discussing any kind of questions, when we are discussing any kind of MCQs, it's all about understanding how your exam questions works, how it can help you to come to the right answer. All right. So passing AMC MCQ is about understanding the important topics, knowing the important topics that can frequently appear in the exam, and also knowing how to come to the right answer in the correct approach. Please do not memorize recalls. Please do not go through recalls only. Our goal is to build your knowledge of theory and then using that particular theory knowledge to answer that questions. And that is the way to go ahead. Also remember that there is no easy way to pass this exam. There is no shortcut. If you do shortcut in your initial part of your life, you will always struggle. You will have to start working as a doctor here in one day, and you'll need to see real patient one day. And if you do shortcut, think about what are you going to do when you are actually a doctor here and you're treating patients. You will do mistakes because you did a shortcut by memorizing some questions. Somehow, even if you're luckiest person in the world and somehow you ended up passing the exam by memorizing these things, still there was a shortcut in your knowledge. There is a huge gap in your knowledge, and that's not how you can proceed as a doctor, like you can't build your career as a doctor in Australia in that way. So throw out those kind of people who are saying all over the social media that just memorize last 1 year recall and you are going to pass the exam, or just memorize some Q bank, you'll be fine. Please do not do that. Okay. I always emphasize on this multiple times in the class because there is always some group of people who will do that. Even if I encourage them, even if I tell them, there is always some group of people who still try to do that and ended up failing the exam. Okay. Please do not do that. Follow what we are doing and do the right approach. I'm sure all of you will be able to pass this exam in your first attempt. So first question, a 56-year-old patient. So even before we go into these kind of questions, when we read a question in the exam, we don't read everything. We read the most important things. 56-year-old patient, so age is really important. What's the main presentation? It's a growing lump on his right hand. So that should be the lump that we're talking about. And what is the likely diagnosis? This is like one line question. In exam, there are questions like this, which is easy if you know it. If you are good with skin and dermatology, you can answer these questions within a second. But if you have never seen this picture before, if you don't know anything about this kind of lump, you'll never be able to come to the right answer, right? So that's where the theory knowledge helps. That's where knowing each and every option, how they actually present, that's the way to come to the right answer. If you don't know how SCC, IEC, BCC presents, you don't know, or you don't actually get the right answer. Okay? Now, there are lots of pattern of questions in exam. Some questions will be single line like this, and many questions are like this. Almost 40% questions will be single line questions. And then few questions will be like multiple sentences are there. And then there are 20 to 30%, which will be a very big and large question, which is going to take your most of the time in the exam. So single line questions like this are easy to answer if you know it. Before we go to our option, we always look at what they are actually asking for. That's a lot of people do it wrong in the exam. There are questions like 7 or 8 or even 10 sentence, like a big questions like this. So patient presented with this, on examination you found this, investigations findings are this. You make a diagnosis of renal cell carcinoma. So they will give you such a big question, but at the end, they will say, you make a diagnosis of renal cell cancer. What will be your treatment? So basically, you don't need to even emphasize a lot on what's written on all of these sentences, because at the end of the day, all you need to know that this patient is a renal cell cancer patient, and we need to know the treatment of this. So sometimes questions are like this. So they write a very large, big question, but in the last sentence, they give you the diagnosis. So always make sure that before you start reading a question, if you see that it's a big question, always look at what's in the last sentence. First, look at what they're asking for. Like, is it diagnosis? Is it investigation? Is it treatment? What is the question? That's the first thing you will read. And then read the line before that did they give any diagnosis in that particular stem? That saves a lot of time in large or big questions. So this is one pattern. All right, I'm just going to remove this. Now, few other things are important. Even before I go into this question, I want you to understand the pattern of questions. In exam, there are different kind of questions that you will come up with. So most of the time they will say, what is the next step of management? What is your initial choice of treatment or initial choice of investigation? Or you can just say, what is the initial step? What is the next most appropriate step? So when they're talking about a step or management, management involves both investigation and actual management, like the treatment. So when they're talking about a step or management, it involves investigations and also the treatment. Okay? So all of this means that you have done something for this patient so far. Like a diabetic patient, you have, let's say, diabetic foot ulcer patient, and patient has a bit of an infection on the wound, and you have taken a swab. The next question will be, what is your next step of treatment? After taking a swab, what we do? We start antibiotic if the wound looks infected. So the next step is, you have done something for the patient, and what are you going to do next? So next means initial. So all of this, next step, initial step, next most appropriate step, all of them are the similar kind of answer, similar kind of question. So basically it means you have done some part of treatment for this patient. What are you going to do next? Then there is another version of question where they will ask, what is your best step of management? Or what is your definitive investigation? What is the definitive treatment for this patient? What's the most appropriate step? Or what is the most appropriate treatment? So when there is no next before this, they're asking about the definitive treatment or the most appropriate treatment. Let's say someone has got same diabetic foot ulcer, and it is a non-healing ulcer, and you can see that wound looks really bad, and you can see that it looks quite deep. Non-healing diabetic foot ulcer looks quite deep. What is your worry? Your worry is that, is it an osteomyelitis? Is the infection reaching the bone? So if that is the case, what will be our definitive investigation, or what will be our most appropriate step? Because we want to diagnose osteomyelitis in that patient. And the definitive, most appropriate, best, everything will be getting an MRI or a bone scan for that patient so that we can first find out whether it is an osteomyelitis and treat the patient right away. So there is a difference between these two type of question. And you will see these two kind of questions almost in every questions in exam. They will ask either next step, initial step, or next most appropriate. Whenever there is next or initial, it means what are you going to do next for this patient? But when there is best, most appropriate, definitive, you don't think about the next step. You think what is the most important, what is the definitive thing that I can do which is going to save this patient? Okay? I hope it makes sense. All right. So let's come to this question. A 56-year-old patient comes with a growing lump on his right hand. So you've got a 56-year-old growing lump on the right hand. The picture shows that there is a erythematous lump. Do you know what is this? This yellow, white, greasy thing, that is the keratin. So whenever you see this keratin on any kind of lump, you think of squamous cell problem. So anything related to squamous cell. Because usually basal cell cancer will not give you keratin. Melanoma will not give you keratin. That's the number one thing that we look at when we see a particular skin cancer related lump. Now, we can immediately rule out BCC, basal cell cancer, and melanoma, because melanoma will be dark pigmented lesion, kind of how you see your freckles or mole. BCC, I'll show you how it looks like later on, but not a keratinized lesion. When there is keratinized lesion, there can be multiple causes. Could be just a simple solar keratosis, or we call it actinic keratosis, which is basically sun-damaged spot. But SK or AK, they don't usually grow. They are not like growing lump. Anything that is growing in an elderly patient, we are always worried about a cancer. IEC is called intraepidermal cancer, or commonly known as Bowen's disease. So this intraepithelial cancer or intraepidermal cancer or Bowen's disease, that's the initial part of squamous cell cancer. So when squamous cell cancer is on the top layer of the epidermis or top layer of the skin, then we call it IEC. IEC doesn't come as a lump. IEC will be flat. I'll show you a picture. But again, this is keratinized. A squamous cell cancer is keratinized. Keratinized means this yellow thing that you can see here, the yellow greasy stuff. And Ka, which is keratoacanthoma, Ka also has keratin on it. So how we differentiate all of this? That's where we really need to have that theory knowledge. First of all, this is Ka, keratoacanthoma. Keratoacanthoma is a variation of a squamous cell cancer, and it has a particular appearance. One that you can see it's a raised lump. So it will be a raised lesion and rapidly growing. They will come to you saying that a lump, I have just noticed over the last couple of weeks, and then it just getting bigger and bigger. But any lump can get bigger. What makes it distinctive of KA? This central keratin plug that we see here, this is known as central keratin plug. Okay? If you see a growing lesion or a lump and there is a central keratin plug like this, that is definitely a possible KA. Now, if we look over here, that's how the IEC or Bowen disease can look like. IEC or Bowen disease will have some changes. You can see it's a bit red. There is keratin all over, but it will not be a lump. Okay, so IEC is usually red or erythematous lesion, which is not a lump, but there will be some keratin on it. So that's IEC. That's keratoacanthoma. What's this then? That is a squamous cell cancer. Squamous cell cancer will present as a lump, which is a growing lump, and sometimes the patient will say it is a bit tender to touch. Sometimes it can bleed, it can be ulcerated, and there will be keratin on it. So you can see a bit of a keratin and also a bit of a lump. So when it is a growing lump with keratin on it, especially in elderly patient, we will be concerned about a squamous cell cancer. So a squamous cell cancer is your answer here. If it was IEC, it would not be a lump. If it is keratoacanthoma, it would be having that central keratin plug. So it's all about excluding the answer or excluding the options in the exam. And the only way you can exclude is when you know about them. Without having a proper knowledge, especially about theory knowledge, you can't actually come to the right answer. How about BCC? So all of these questions are pretty common in exam. So BCC, SCC, melanoma, they come frequently in exam. Okay, so you have to know about them. And in the class, when we take dermatology class, we will discuss this in a bit more detailed way. In question solve classes, we just focus. We don't go too much detail. Have a look at this picture. So you can see that there is also a raised lump, but the lump doesn't have any keratin on it, right? The most important thing is the BCC look like a pearly appearance. So it has a pearly appearance. And also you can see the telangiectasia, which is these tortuous blood vessels, which is going towards the center. So all of these tortuous blood vessels, or we also call them arborizing blood vessels. So if we see a pearly nodule or a lump with this kind of arborizing blood vessels, or you can just remember as telangiectasia, you can't actually see this, but at least you can see that this is a pearly lump. That's BCC. Okay? Make sense, everyone? All good? Clear? Move on to the next one. We have got a 50-year-old male. So again, always remember and always see what I am taking from the question. 50-year-old male presents to the ED with shortness of breath, difficulty speaking. He has significant neck pain, very important in a patient with shortness of breath, difficulty speaking, and will not allow examination or manipulation of the neck. Vital signs are currently within normal limits, so he is stable. What is the most appropriate initial step? See, that's how the question will come. So we need to know what's going to be our next step, right? So we have got a patient many times they will say that this is most probably a case of motor vehicle accident. So that's because sometimes the questions will not have the full questions. So you can see that it's probably a patient who had a motor vehicle accident or some kind of road traffic accident, and then coming to the emergency department with shortness of breath and difficulty speaking. So you've got SOB, we've got significant neck pain, and patient will not allow manipulation as well. So that means it's quite painful, and we have got a stable patient at least. So these are our important thing to take. And even the first thing is this is a motor vehicle accident patient. Our options are jaw thrust and head tilt alone, head tilt, chin lift, insert a oropharyngeal airway, and apply cervical collar before attempting airway management. What are we going to do? Now, so tell me about, like, if a patient comes to us with motor vehicle accident and having shortness of breath, significant neck pain, what do we do first? What is the first thing that we do? A, B, C, D, E. That's what I wanted to know. Primary survey, guys. Okay, so A, B, C, D, E. So primary survey is our first thing that we do. In a patient with motor vehicle accident, they come to the emergency department. We're going to start with A, B, C, D, E. Now, I know that the answer is not that difficult, but knowing the topic is important. Understanding the primary survey is important because there are a lot of questions that come from here. Let's talk about it and then we will come back to this. So primary survey starts with airway. So we need to protect the airway, check the breathing, make sure the circulation is stable. Disability, which is basically neurological status of the patient, and exposure. So let's talk about how we assess airway. When a patient comes to us, the first thing, especially after a motor vehicle accident, we need to make sure that the patient's airway is patent. How we know that? If a patient is talking without any kind of external sound, no hoarseness of voice, no gurgling, no stridor, no wheezing that you can hear, that means airway is patent. So in that case, you can go to the B, which is checking the breathing. But if you see that patient is having active shortness of breath, like you can see patient is cyanosed, using the accessory muscle, like you can see the neck muscle is, you can see that the patient is using the neck muscle. There is angioedema or facial swelling, which is suggesting anaphylaxis. So any of those, if it is there, and you can also listen for a stridor, gargling sound, any of this is there, means that patient's airway is not patent. What do we do then? So if a patient's airway is not patent, we need to open up the airway. We need to protect the airway. If there is no suspected cervical spine injury, how do we know that? So one, that patient will complain that my neck hurts. And sometimes we ask the patient to move the neck if it is not painful. If the first patient says there is no pain, and patient is able to move the neck without any pain, it means it's okay. And then sometimes we also press on the cervical spine to check for any cervical spine tenderness. If none of them are there, CS spine is good. So if there is no suspected CS spine injury, then to open up the airway, we do this procedure called head tilt, chin lift. Now, if you have never seen that, it's gonna make you really, really confused. So let me just show you what does it mean. So you can see this one. So you're tilting the head backward. So when you're tilting the head backward, there is hyperextension of the neck. That's why we always make sure that cervical spine is not injured before we consider doing the head tilt chin lift. Because if there is cervical spine injury and you do this, you can cause more damage. You can end up causing paraplegia or quadriplegia for this patient, basically quadriplegia. Okay? So it's very important that before we consider doing the head tilt, so you're tilting the head back and then lifting the chin so that the airway get more open. Before you do that, you need to make sure the CS spine is not injured. If patient complains that, yes, my neck is hurting, I don't want you to move my neck, definitely there is a problem. In that case, you do not do head tilt chin lift. Rather, you do the jaw thrust. So just put your hand below the angle of the mandible and just pressure the jaw to open it upward like this. So that's called jaw thrust. So jaw thrust is a procedure that we will do if we suspect CS spine injury. And if there is no CS spine injury, then we can go for head tilt chin lift. Okay? Remember one thing, before we go for jaw thrust, we will need to protect the cervical spine. And how we do that? We put a collar. So the neck collar will stabilize the cervical spine, and then you can go for jaw thrust. Okay? Let's say our patient's airway is patent, or we have protected the airway. The next thing is checking the breathing. How to assess breathing? First, check the respiratory rate, check the oxygen saturation, so SpO2 with pulse oximeter, and then examine the chest. So listen to the chest, percuss the chest, just do the full respiratory examination. If you suspect there might be something wrong, like saturation is less than 95, you can see that during the examination of the chest, you suspect there might be pneumothorax, hemothorax, then yes, we will do some investigation like ABG, arterial blood gas analysis, and chest X-ray. The immediate management for patients with breathing issues depends on the cause. Whatever cause we find, we will treat it accordingly. But the first thing is sit the patient upright if it is conscious patient, and start oxygen if saturation is less than 95. You want to keep the saturation more than 94%. Okay? Then, after breathing, we go for circulation. So circulation, how do we check it? Check the blood pressure, check the heart rate. That's the main thing. If a patient has blood pressure less than 90/60 and pulse more than 100, that is a patient who is in shock. In a patient who has motor vehicle accident and they're in shock, what's our main concern? Bleeding, massive bleeding, right? That's why nowadays, before A, B, C, D, A, there is another thing that we use. This is a new thing. It's called catastrophic hemorrhage. So it's also important because a lot of time, so you can see even it comes before airway. Because if a patient is having catastrophic bleeding, that could be the end of life. That could be the cause of death, and it can happen very fast. So finding out or detecting catastrophic hemorrhage is a really important thing in a trauma patient. I'll show you the Trauma Victoria guideline so that you can understand what I'm talking about. Okay. Now, not everyone will have catastrophic hemorrhage. Some patient can have mild bleeding. Okay. But if a patient bleeds continuously, they will go into hemorrhagic shock. And that's what we will find out in that patient. Also look for pallor, sweating, calmness, check the capillary refilling, check JVP, heart sound, all of the necessary things. Investigations, or what we are going to do in a patient who is in shock, we will insert IV line, we will take some necessary blood and start the patient with IV fluid if it is appropriate. There's a lot to discuss in here. Not every shock needs IV fluid. If a patient after motor vehicle accident presents with shock, it could be either a hypovolemic shock, which is basically hemorrhagic shock, or it could be cardiogenic shock. Hemorrhagic shock, it's easy to detect because in that patient, the central venous pressure or the JVP, or you can say the central venous pressure, will get low because there is not enough blood. So definitely the neck vein, so neck vein will collapse. So you'll not be able to get raised JVP in this patient, definitely. But in a cardiogenic shock, which can be due to cardiac tamponade. So cardiac tamponade is a condition where, so we have got, this is our heart, and around the heart you have got the pericardium. And if due to motor vehicle accident, there is accumulation of blood in this pericardial space, and more blood will accumulate in the pericardial space, and heart will not be able to move. So the blood from outside will start to push the heart. So heart will not be able to pump. So that's the time the heart will go to cardiac shock. Now, because it's not able to move, the blood is not able to come into the heart also from superior vena cava or from the neck. So that's why in this kind of patient, you will get raised JVP. When we discuss cardiology, you will understand this tamponade in much better way. I will discuss it. So don't worry if you're not understanding it today. So in cardiac tamponade, the neck vein will be distended. Okay. Is there anything else which can cause shock in a motor vehicle accident? Can you guys remember? Yes, neurogenic shock. That's fine. There is another thing which can also present as shock, especially after motor vehicle accident, is tension pneumothorax. Yes, very good. In tension pneumothorax, patient's main presentation will be chest pain and shortness of breath. You can also get raised JVP in tension pneumothorax. But in tension pneumothorax, you will get all the respiratory finding like hyperresonant percussion node, all of those things will come up. So it's a respiratory presentation in that case. So these are the three major causes, or if you add neurogenic shock also, these are the four major causes of shock after motor vehicle accident. Finding it out is important because if you give IV fluid in a patient with cardiogenic shock, you'll make it worse. Okay? So that's why do not just start IV fluid just because someone had a motor vehicle accident and is in shock, because you can actually promote the death of the patient by giving IV fluid. So please don't do that. All right? So check for all of this. Make sure you have got the right cause of the bleeding and shock and then treat it. If it is hemorrhagic shock, yes, then start with IV fluid, send the blood for grouping, cross-matching, and if the blood is available, you can also start blood transfusion if it is indicated. Okay, so that's all we have written in here. Then we have got D. D for disability, which is basically checking the neurological status of the patient and checking for any hypoglycemia or hyperglycemia, such as diabetic ketoacidosis or hyperosmolar glycemic coma. Now, in a patient with motor vehicle accident, a quick way of checking their neurological status is called ACVPU or AFPU. So with AFPU, we have got is the patient alert or is the patient confused? Does he respond to voice? If not, does he respond to pain or unresponsive? This gives a good idea. Normally, for a better neurological status, we do the GCS. But we don't have that much time in the primary survey, so we just do this quickly. Is this patient alert, confused, responding to voice, responding to pain, or if it is unresponsive? Check the pupil size, do a brief neurological assessment, check the blood glucose, check the ketone. So that's mainly what we do in the disability part. So mainly neurological status and the blood glucose. And the last one is exposure, which is just exposing the whole body to find out any other obvious injury. It's important to know that if a patient's GCS is less than 8, less than equal to 8, that patient's is most likely the patient's airway is not intact. So airway is most likely obstructed and they will not be able to protect their airway by themselves. So any patients who is unconscious or their GCS less than equal to 8 needs to have airway protection immediately. So that means they will need endotracheal intubation. So this is a brief idea about primary survey. You will get a lot of questions related to this discussion that we just had today. But again, lot to learn. But this is a generalized idea, which is more than enough to answer many, many questions that can come in exam from this topic. Let's come back. So in this patient, we have got shortness of breath, we have got neck pain, difficulty speaking. The first thing is, we don't know at the moment what's really happening. Is this patient airway protected or not? Seems like that if it is a motor vehicle accident patient having shortness of breath and difficulty speaking, remember we said, is the patient able to talk? That means airway patent. If the patient is having difficulty to talk, that means airway is getting obstructed or it's already obstructed. So we need to protect the airway for this patient. Before we protect, we need to make sure that whether the C spine might be injured. This patient seems like C spine is injured. So we're going to apply a cervical collar before we attempt the airway management. If they already mentioned in the question that the cervical collar is already there, what we will do next? Yeah. So we just learned, right? We can't do head tilt, chin lift in those situations. So if the patient has got neck injury, possible neck injury, what we will do? Ideally, jaw thrust. So jaw thrust will be our option in that case. All right. So head tilt is usually not needed. Jaw thrust is usually the ideal thing, but definitely we don't need to do head tilt, chin lift. Those things we don't need it. And intubation immediately is not needed. Before you go for intubation, you can at least remember this is the primary survey. The primary survey is first try to open the airway with the normal maneuver. All right, I hope it's clear. Sarah, this class is already recorded. It will be uploaded in the YouTube, so please don't worry. If you have got emergency, please go and check it, and the class will be recorded anyway. Don't worry. Is it clear for everyone? Any questions about this? Oh, it is A, ARPA. So at the moment, so these questions, the answer is A. But I mentioned that if the question said, so sometimes, so let's say the question just added a line that you have applied cervical collar. That means you have protected the airway, you have protected the neck. What we will do next? The next will be jaw thrust. Let's move on to the next question. A 7-year-old child is brought to the GP with recurrent episodes of severe vomiting over the past 8 months. During each episode, the child vomits multiple times over several hours and unable to tolerate oral intake. Between episodes, the child is completely well. That's a very important line. What is the most likely diagnosis? Gastroesophageal reflux, intussusception, cyclic vomiting syndrome, celiac disease, or raised ICP. Now, many of you don't have ideas about a lot of these. Let's clear it up a little bit. First of all, look at the child age. It's a 7-year-old. We have got recurrent episodes of vomiting. So 7-year-old, we have got recurrent vomiting episodes. And in between, so between episodes, child is well, completely normal. So these are the three things that I want to look at. So let's try to do exclusion. So gastroesophageal reflux disease, is it common in a 7-year-old? No. It's common in less than 12 months. So less than a year old, children can have gastroesophageal reflux because this is a physiological phenomenon, and the presentation will be every time the child is having some food or milk, the child just vomits out. But apart from that, child is fine, growing well, not losing any body weight, everything else is fine. It just after having a milk or some food, child vomits a little bit. And usually it gets better after 12 to 18 months of age. So it's not common to have a 7-year to have a gastroesophageal reflux disease, especially not with this presentation. Intussusception, not common for 7-year-olds, but it can happen. So intussusception, the presentation is quite different. The children will not have the symptom for 8 months. That's the first thing, because it's an acute presentation. It's kind of like a telescoping of one bowel into another. So if this is one bowel, the other part of the bowel goes into that, and they form an obstruction here. With intussusception, children comes to us with sudden onset of severe screaming episodes. So they come to us with severe screaming because it hurts a lot. So children who can't say I'm having tummy pain or abdominal pain, they will just scream because it hurts. And it's the episodic. So it's a episodic or colicky screaming. If the child is a bit older, they can just say I'm having a lot of abdominal pain. So episodic screaming, yes, they can get bile-stained vomiting, and they will get what we call a red currant jelly-like stool or diarrhea. Not always there, but this is a main presentation is episodic screaming or abdominal pain with bile-stained vomiting. Again, this will be acute presentation, not for months. So intussusception is very unlikely. Celiac disease. Celiac disease is nothing but gluten sensitivity. So patient, especially a lot of Australians, they have gluten sensitivity. What contains gluten? So gluten is in almost all the breakfasts that we take. So the cereals that you're taking, which contains wheat, rye, oats, barley. Yeah, so brow, right? So anything. So breads, cereals, almost every breakfast will have some gluten in it. So patient who has celiac disease, they cannot tolerate this in their diet. So what happens that when they have this kind of food, they present to you with abdominal bloating. So their main presentation will be bloating or distension of the tummy. And they have chronic malabsorption diarrhea. So because in patient with celiac disease, their intestinal villi becomes flattened. And because of that, the food that they are taking, they cannot absorb it. So everything just goes out as diarrhea. So patient with gluten sensitivity or celiac disease, the main presentation is chronic malabsorption diarrhea. And what is malabsorption diarrhea? Malabsorption diarrhea is patient saying that I get this explosive, bubbly, frothy, foul, smelly, hard to flush, greasy stool. Again, foul, smelly, bulky, explosive, frothy, bubbly, hard to flush, greasy stool. Okay, so that's how they will explain. Yeah, steatorrhea. So when a patient complains like that and they say that it happens every time I have my cereals in the morning, you know the diagnosis. All right. Again, this will not come to you with episodes of severe vomiting. Unlikely. Raised intracranial pressure. Raised intracranial pressure, the main presentation will be headache. Without headache, we don't even think about it. And there is no headache in this patient. So everything is out. Just by exclusion, we can remove all the other options. Your diagnosis in here is cyclic vomiting syndrome. So what is cyclic vomiting syndrome? So it's a diagnosis of exclusion. You cannot just make a diagnosis of cyclic vomiting syndrome just by looking at the patient's history. You have to rule out all the other possible causes, and then you can come to this diagnosis. So it is characterized by recurrent episodes of intense nausea and vomiting. And then there will be periods of completely normal health. So patient will get these few days or weeks of intense nausea, vomiting, and then for months and months, nothing will happen. Again, there will be another episodes lasting for hours or days, and then again, there is complete normal health. This is why it's called cyclic vomiting syndrome. Why it occurs is not fully understood, but it is believed that it might have some kind of gut and brain interaction, kind of IBS. So when the nervous system is stressed due to any reason, it can interact in the gut. So gut can play up a little bit. Okay. So it is considered a brain-gut interaction disorder. Usually they say that there is abnormal signal between the brain, nervous system, and the GIT. It is common in patients who has migraine or family history of migraine. The common triggers are stress, infection, lack of sleep, starvation, dehydration, and certain foods. Okay? There is a good discussion about this in Perth Health. Let me show you. This is the Australian guideline. Sorry, Western Australia guideline or Perth Children Hospital guideline. And they have discussed it quite nicely. So cyclic vomiting syndrome, it's a recurrent episodes identified by at least 3 or more episodes of nausea, vomiting, lasting from hours to days, separated by complete symptom-free intervals. It is common in between 3 to 7 years, so preschool or early school age group. Assessment, nausea and vomiting is usually the presentation. Management, exclude all other causes of vomiting. That's the first thing you do. So any causes of vomiting in a child has to be ruled out. Assess the hydration status, because children who is vomiting a lot, they can get dehydrated. They can lose a lot of potassium. So check for electrolyte. What we can do in that acute stage to reduce the vomiting, if the child looks dehydrated, then yes, administer IV fluid if it is needed, especially if it is severe dehydration, and offer antiemetic medication. The first line antiemetic for children more than 2 will be ondansetron. Remember, in AMC MCQ, you do not need to know the dose of the medication, only need to know the name of the medication. If ondansetron doesn't help, then we have option of trying chlorpromazine. So it is useful in patient where ondansetron doesn't control the nausea and vomiting. So just remember these two names because it's all about understanding the topic. As I say multiple times that when we see a particular topic is coming in exam or important for exam, you should know each and everything about that particular topic. Management, investigations, how to come to the diagnosis, everything. And a good way of learning a topic is, let's say I want to know everything about cyclical vomiting syndrome. First, I will read it from a guideline, like this is the guideline, and then I will make short note on it. What is a short note? So what's the main symptom of this condition? What are the main examination finding? What will be my investigation? When we do the investigation, what's the initial investigation? And what's the best or definitive investigation? What will be my management? What's the initial management? And what's the best management? That's the only thing you need to know for every topic, because the questions will come from this. If you don't know symptoms and examination finding, you cannot come to the diagnosis. If you cannot come to the diagnosis, you don't know what investigation to do or how to manage it, right? So that's the main format for every topic that you need to learn. You need to know this, okay? Not a lot of things if you think in this way. Next question, a 17-year-old boy presented with throbbing global headache and nausea, vomiting, no aura, currently on doxycycline for acne. History of intermittent headache and nausea, vitals is stable. What is the initial step? To know the initial step, we need to know what is the cause of the headache. 17-year-old, throbbing global headache with nausea or vomiting. What do you think this patient might have? Can it be migraine? Why not? Aura is not always a presentation of migraine. Only a few patients will have classic aura. Okay? Yes. One of the important presentation for migraine is that it's unilateral. It can be pulsating, throbbing headache. It can have associated nausea, vomiting. Aura is not a particular thing to come to the diagnosis of migraine. If they have aura, that's good. That's what we call classic migraine. And without aura, that's common migraine. So you can understand that there is common presentation to have a migraine without aura. So the only difference is most of the common migraine will have a unilateral pulsatile throbbing headache. Global headache is not a common presentation. It can happen. Migraine has so many subtypes, and it is still not well understood how all of this occurs. It can happen, but it's atypical. And we don't think about the atypical in the exam a lot. We think about the common things. So it's unlikely to be migraine. And also important is when we look at the option doesn't go with migraine because migraine patient doesn't need any of this. They don't need EEG. They don't need CT head, MRI brain. Often In exam, when you are not sure what could be the diagnosis of that particular stem or question, look at the option. Sometimes option will give away some of the things that you're thinking in your head. Okay? Now, yes, it is right. It is what we call idiopathic intracranial hypertension. Idiopathic intracranial hypertension is common in female. It's common in young, obese female. Now, just because this is a male, we cannot exclude that. So sex alone is not the only thing that will lead us to rule out a complete disease or condition. Okay, but yes, we should know the common thing. So yes, the raised ICP or idiopathic intracranial hypertension, it is common in female who has BMI more than 25. So this is from therapeutic guideline. We use therapeutic guideline a lot, which is really a good updated guideline. Now, idiopathic intracranial hypertension means that patient has raised intracranial pressure and there is no cause of that. It just happened. The feature of the headache, so headache will be like this. It is diffuse and global headache. There can be associated nausea, vomiting. The headache has some specific pattern. Problem is in AMC, MCQ, you don't get everything in the stem. They only give few tips. You don't get all the things to come to the diagnosis. That would be really easy if they would give you everything. Now, the headache in idiopathic intracranial hypertension, the headache will get worse with lying down or bending forward. It will improve by upright posture, aggravated by cough or straining. So anything that puts a bit of a pressure will aggravate the headache. They can have also associated transient visual loss and pulsatile tinnitus, so ringing noise in the ear. It's not always, but it can be. Papilloedema is a key feature. That means when you look into the eye with an ophthalmoscope or fundoscope, you will see papilloedema, which is swelling of the optic disc. If you get that and patient has got this kind of headache, that becomes a ophthalmologic urgency or medical emergency. So you need to send the patient right away to an ophthalmologist. So if idiopathic intracranial hypertension is suspected, refer to neurologist urgently. To confirm the diagnosis, lumbar puncture manometry should be performed. So the lumbar puncture manometry will be able to say that patient has got a pressure more than 25, and that will be confirmatory for this diagnosis. So again, what is the presentation of idiopathic intracranial hypertension? Patient comes to us with global throbbing headache, the headache that gets worse with lying down, bending forward, or straining, may have associated visual field loss and pulsatile tinnitus. If we suspect this, we should send the patient to a neurologist who will consider doing a lumbar puncture, and they will do the manometry to find out the pressure of the pressure inside the head. If the pressure is more than 25, it will confirm the diagnosis. Treatment. Always remember that there are lots of medications which can give the same kind of presentation. So you can see here, actually this is not written in here. So there are certain medications which can cause raised intracranial pressure or raised or idiopathic intracranial hypertension. Do you know what are the medications which can cause that? So number one, any vitamin A derivatives, like we use isotretinoin. That's for skin. Sometimes we use it for acne. Tetracycline. That's your doxycycline, minocycline. If you use growth hormone for a patient, and sometimes it can be effect of corticosteroid. So these are our common medications which can cause raised intracranial pressure. So our patient is on doxycycline for acne. That is the first thing we will do. Stop doxycycline. Because if there is a drug which might cause this, then the first thing that we do in any kind of condition is they stop that drug and see how the patient goes. Because it could be just that. We don't need to do anything else. Just stopping the medication might relieve the pressure and patient's headache can get better. Okay? So first of all, find out whether the patient is on any kind of medication. You can see it's also given here. Some drugs, doxycycline, isotretinoin, can cause raised ICP. So basically, the question actually came from therapeutic guidelines. Treatment. So once you have done all of this, remember if vision is affected and you are suspecting this condition, it's a medical emergency. In that case, performing lumbar puncture can relieve the pressure and save the eye. So this can become both diagnostic and therapeutic. Apart from that, what else we can do? The most effective long-term treatment is if a patient is overweight is to reduce the weight. So weight loss will help the patient to get better with this intracranial pressure. And some of the weight loss medications like semaglutide, which is very hyped at the moment, like Ozempic, and lots of other weight loss treatment, that is a very good idea for this group of patients. What else we can do in addition to weight loss intervention? We can give them acetazolamide that can reduce the pressure. We have option of giving topiramate. Okay, so remember, if the patient's vision is affected, then the treatment, diagnosis and treatment both will be lumbar puncture. And then as a long-term management, weight loss is the main treatment of choice, and you can give them semaglutide injection, which is the GLP-1 receptor agonist, and that will gradually help the patient to lose the weight and the intracranial pressure will get better. What else we can do? We can give them acetazolamide or topiramate. Just remember the name of these medications. Sometimes this can come in exam. All right, good. You guys are doing really good. And many of you are coming to the right answer. Many of you are interacting. So that's really, really good. That means you're not amateur. You are in the right direction. I'm really happy to see a lot of right answer in here. All right, let me take a 5-minute break. And you guys also have some coffee or tea, whatever is your tonic, and then we come back after 5 minutes. Okay? 5-minute break, guys. Thank you. All right, guys, let's start again. So how are you guys going with these questions? Are you guys learning something? Are you enjoying the session? Is it too difficult? Great. All right, let's move on. So we've got a young boy brought to the rural hospital emergency department after trauma to the head. So it's a head injury patient. He was in a motor vehicle accident, unconscious with GCS 6 by 15, and you have already intubated the patient. We know that if it is less than equal to 8, we go for endotracheal intubation. The neurosurgery unit is 3 hours from the rural ER. What will you do next? It's a very commonly asked question in the exam. Rural hospital head injury management. And head injury itself come in exam a lot, okay? So knowing the right step of head injury management is really important. So what do you think this young boy will need? So we've got a patient who is unconscious, definitely comatose. Intubation is done to protect the airway, but the neurosurgery unit is 3 hours from the ER. Are we going to transfer, do a CT scan, bar hole, or craniectomy? Remember one thing, that's a very important thing to know. If something is given in the option, means it is available. There's a lot of question. Like I can see even Vashkar, you asked that question, right? Is CT available? It is important to understand, and it is also given in AMC MCQ a specific guideline. The guideline MCQ has given that if in the option something is there, it means it is available. And so if something is not given in a option in a particular stem, it is likely that it is not present in that patient. But sometimes the rule can change a little bit. I will talk about it. There is a question which I will show you later on. Now, this is a very important flowchart of head injury management in a country hospital or rural hospital. So if we have got a patient who has got serious head injury, and by serious head injury, any patients whose GCS is less than 9, it's a serious head injury. And our patient's GCS is 6 by 15. So we will assess and discuss this with the neurosurgeon. So neurosurgeon should be involved in the tertiary hospital. And then how long it will take for this patient to be transferred to the tertiary hospital, that is important. If it is less than 2-hour distance, that yes, within 2 hours, you can send this patient to tertiary hospital. In that particular case, you start all the necessary treatment and transfer the patient. All right. So the necessary treatment is if GCS less than 9, then yes, intubation will be our priority. You can give them mannitol, which will reduce the intracranial pressure, and moderate hyperventilation. So all of this can be done in that patient while the air ambulance comes to pick up the patient to transfer to neurosurgical unit. If it is more than 2 hours, like our patient having more than 2-hour distance, that patient will deteriorate on the way to go to the tertiary hospital. So you don't have that time. In that case, definitely if CT scan is available, after intubation, you can organize a CT. Okay, so CT scan is important because without CT, we are just blindly trying to find out what happened to this patient. So more than 2-hour distance, if CT available, yes, we will do the CT. We will start mannitol and moderate hyperventilation. And the treatment at the time will be bar hole evacuation of clot in the rural hospital. So there are rural emergency department where there are doctors who can do it. So because your job is to save this patient. And the only way at this time will be bar hole and trying to remove any clot that might be causing this problem. So if it is more than 2 hour distance, definitely the airway management comes first. GCS less than 9, intubate the patient. If CT available, do the CT scan, find out what's really happening, where exactly is the clot. Start the patient with mannitol, moderate hyperventilation, and then go for bar hole. And then in the meantime, await for the retrieval team to take him to the tertiary hospital. Okay? If CT is not available, then still you will go for blind bar hole evacuation. Most of the time, you will be able to know that where exactly is the clot, because you will see that there will be bruising, swelling, hematoma, and that's usually where the head injury is. And most of the time, it is the temple area where patient gets most of the common head injuries. So yes, to save the patient, we might need to even go for this kind of blind bar hole evacuation of clots. Okay? So that is the treatment. Now, all of this came from this guideline. So let's have a look at this important guideline for head injury. So this is the Australian emergency guideline. So you can, this is one of the things that you should definitely read everything from here. Okay, but I'm going to show you the important part from here. They also talked about primary survey, area, the ABCDE. What are the indications of CT scan after a head injury? Not every patient who will get a head injury, you need to organize CT scan. That's common mistake that any patient coming with head injury, we just send them for CT scan. Not all the time. In Australia, there is particular indication to organize a CT scan. GCS less than 9. If neurological deterioration, initially GCS was 15, but rapidly it just going down, so now it's 13. So 2 or more point on the GCS if there is a deterioration. If the patient is drowsy, confused, persistent headache, vomiting, fracture, any of these, patient had a seizure, any of this is an indication to get a CT scan of the head. You can see the common hematoma that patient can develop after a head injury. So if there is, this is a CT scan of the brain. In CT scan, brain looks gray color. And if there is any blood, it will look white color. All right. A epidural hematoma or extradural hematoma will be biconvex shape. You can appreciate the biconvex shape here. That's what we will get in epidural hematoma. And if it is a subdural hematoma, it will be crescent shape, like this. So that is usually important to hematoma that can happen after head injury. You can see the fracture of the skull. And in here, there is the flowchart that I have taken. So same thing. Now coming back to this question, what do you think will be our next step in this patient? Yeah, we'll do a CT scan, because if intubation was not done, yes, we would do intubation first and then CT. Because it's more than 3 hours away, we cannot transfer the patient at the moment. Okay, good. A 23-year-old, actually it should be motocross rider, 23-year-old motocross rider is brought to the emergency department. Okay, you've got some questions. So after CT scan, do we go for bar hole or cranio? Remember, after CT scan, if there is an option of mannitol, hyperventilations, those will be our next step before we go for bar hole. Okay, so bar hole will be our definitive treatment in this patient. Now, Talha, best step in this question. So sometimes if they say best step, Best step also means what is the best step at this point for this patient. After intubation, the best step is CT scan. Okay. Usually these kind of things, this kind of question doesn't actually ask for best step. They usually say, what is the next best step? Like you can see here, what is the next step? Because this is something which is a step-by-step approach. In a step-by-step, they usually ask the question as what's going to be your next step? If it is less than 2 hours, then it is not must to organize a CT scan. Depends on how long the transfer team is. If the transfer team is a bit, it's going to take some time, then yes, we can organize a CT, but it's not must to do a CT before we transfer. No, it is available. CT is available in rural hospital. It's not uncommon. Most of the, unless it is a remote hospital, CT will not be available. The question is not that. Always remember, C, as I said, if an option is there of CT scan, it means it is available. That is the AMC guideline. If they have given you an option, it means that it is available. Okay? If it is not available, they will write it on the stem that you don't have options of CT scan in this hospital. Yeah, if it is less than 2 hour distance, you can see that before transfer, still there are a few things you can do. Depends. Does this patient need an intubation? Then you intubate the patient. Start mannitol, hyperventilation. So all of these needed to be done before we transfer. Okay, so we involve the neurosurgical unit. We will start the transfer process, but in the meantime, while we wait, we will do all this specific management in the meantime. Okay. All right, let's move on. A 23-year-old motocross rider is brought to the emergency department following an accident. There is a 6 centimeter laceration over the anterior aspect of the tibia, which is clearly deformed. His foot is well perfused. Which of the following is the most appropriate initial step of management? So we have got a patient who has got 6 centimeter laceration on the tibia, which is clearly deformed. What is this called? This is likely to be an open fracture. So when there is a deformed limb, and on the top of the deformed limb, there is laceration, it means it's an open fracture. So in an open fracture patient, the first thing definitely we need to check what is the neurovascular status of the limb. So we can see the foot is well perfused, which means there is no nerve or any vascular compromise in this patient. Then what we are going to do? IV antibiotics, fracture reduction, lavage, surgical debridement. Remember, initial step. They're not asking about best step or definitive treatment. That's why knowing the question or knowing what they're asking is important, right? See? So debridement, you're not just doing the debridement right away. The question is about initial step. Always there is a step-by-step that we do, okay? And we don't do debridement in an emergency department. Patient will not be able to tolerate that. So important thing is reading the question, what they're asking. And do not just answer any question without reading the full question. Do not answer without knowing what they're asking. Always always read this line, that what they're asking for. Is it the best step? Is it the initial step? And then try to think that this is a patient with open fracture. I can see that there is clearly a laceration, but neurovascular status is good. So I do not need to reduce the fracture right away because neurovascular status is fine. If this patient was, they were saying that patient foot is showing pallor or there is paresthesia. So if there was sign of neurovascular compromise, then we need to do the reduction right away, right? Because if we don't do the reduction, the foot will get more and more vascular or neurological compromise. So it depends on what we say in the question, and then based on that, we will answer the right option. Now, before we can see the options of IV antibiotic, fracture reduction, lavage, surgical debridement, and tetanus. Let's have a look. This is a very good discussion about open fracture treatment, and open fracture comes in exam always. It's like a question which will always come. So knowing this by heart is important. So this is what we call open fracture. You can see that there is a laceration, deformation. You can even see the bone here. Let's talk about it. So any patient after a major trauma should be fully assessed. So first thing you will do is A, B, C, D, E. Always make sure in any patient with a major trauma, the first thing is primary survey. Then when you come to the limb should be assessed for sign of fracture. So when you do the exposure part of ABCD, that's where you will start looking at the limbs. And also you do secondary survey where you check everything. So check the limbs for any fracture, check for any wound. The distal neurovascular function should be assessed. So that's why the question said that the foot is well perfused. So neurovascular assessment should be done. Gross contamination may be removed. So if there is like lots of dirt, you can try to remove them, but you do not probe the wound, or you do not do debridement in the emergency department because patient will be in a lot of pain. The fracture should be grossly realigned and limb is splinted, just like immobilizing the limbs, because every time the patient is moving the limb, it's causing more problem. That is where our answer is. Tetanus and antibiotics should be given urgently. It is accepted that earlier antibiotics are given, the better. All right? So it's very important that we give antibiotics proactively in any open fracture. Then after that, so once you have done the initial management, so initial steps are done, then you take the patient to the OT for adequate wound assessment, debridement, and lavage. So debridement, wound lavage, everything will be done in the operation theater. And then you will definitely treat the fracture as well. Okay? So if we talk about this step, in an open fracture patient, neurovascular assessment is must. Any kind of fracture, which we should always do the neurovascular assessment. Then, if the neurovascular assessment says that there is compromise or the neurovascular status is not intact in the limbs, in that case, we will do fracture reduction. And it can be done under sedation, like light sedation. Because without reduction, the nerve or the vessel is getting pressure and it will have more and more damage. But if the neurovascular status is intact, like this patient, then the first thing we do is giving a good painkiller, must, because patient who has open fracture, they're in a lot of pain and they can go to neurogenic shock because of the pain. So painkiller should come as our first treatment in this kind of case. We don't have that option here, but if it is, that will even come before antibiotics. After that, we go for IV antibiotic. Then we go for tetanus if indicated. There is a good discussion about tetanus immunization or vaccination, but as a general rule, understand that if a patient had at least 3 tetanus vaccine during their childhood, and we also look at when was their last booster. If the last booster was more than 5 years ago, plus we have got a tetanus prone wound. So the wound looks like can get tetanus, especially any motor vehicle accident. In that case, we will only give them tetanus toxoid vaccine, which is commonly in Australia known as ADT. Okay, so ADT has diphtheria and tetanus in it. So more than 5, so patient who had 3 vaccinations during their childhood, that means they completed vaccination, plus they have got a booster more than 5 years ago, and it is a tetanus prone wound, then we give only tetanus toxoid vaccine. Not every patient will need a tetanus. Because this patient, we don't know what's the tetanus vaccination status of this patient, we are not choosing the tetanus in here. Now, if we need to choose between A and E, antibiotics and tetanus, antibiotics will always come first. Okay, we will discuss about the tetanus vaccination in detail in the course. We cannot go into like multiple things when we do discussion of one particular thing. Tetanus is a whole topic. We will discuss that later on. But just a understanding that if a patient had their last booster dose of tetanus more than 5 years ago, and their wound is tetanus prone wound, means that the wound got soiled with if the wound got touched with soil or any kind of rusty metals, garden tools, they are all tetanus prone wound. For that patient, we will need to give them tetanus toxoid. Okay? So in these patients, IV antibiotic will be our right answer. So again, painkiller, IV antibiotic, tetanus, and then you can take the patient to the OT for surgical debridement, lavage, and definitive fracture treatment. Make sense? All good? Everyone good with this? Because you will get a lot of confusion. Same questions. If you see a patient sustains crush injury, examination shows a severe open wound of the lower limb with an absent dorsalis pedis pulse. So this is a patient whose neurovascular status is not intact. Most appropriate immediate management of the wound. Now, the immediate management should be reduction. It's not in the option, but who knows? Number E might be reduction. Okay, so if reduction is there, then yes, reduction should come there. If not, because still it is an open wound, we will choose the immediate antibiotics. It's just doing serial neurovascular assessment is not going to work for this patient only. We need to give something. Daily wound dressing, not at the moment. Compression bandage, definitely a no for an open fracture. Okay, so that's what I say, that it's not about just memorizing these questions, it's about knowing the step by step. Now you know the step, and any kind of questions related to open fracture, you will be able to come to the right answer. All right? All right. Now, going to the diabetic question that I was talking about initially. So we have got a diabetic patient with food ulcer. And if we look at the food ulcer, let's say that, so this could be the food ulcers in a diabetic patient. You can see that. So diabetic food ulcer comes in a lot of ways in exam. So that's why I discuss it in very detailed way. So let's say we have got a diabetic foot ulcer patient, which is non-healing. So they will say that a patient comes to you with a known type 2 diabetes or type 1 diabetes. There is ulcer on his right foot for 3 weeks. It's not been healing at all. And they will say that he is admitted, antibiotic was given, swabs has been taken. What will you do after that? So this is a kind of questions that comes under this. So our main understanding is that if it is a diabetic foot ulcer and if it is not healing at all for more than 2 weeks, it is at risk of causing osteomyelitis. Not every one of them will do it, but looking at the wound will give us a better idea that whether it has risk or not. Because when it is causing osteomyelitis, there will be a lot of pain, it will get swollen, red, it will look extremely infected. So the question is, if there is a diabetic foot ulcer and you are concerned about that patient, what will you do next? X-ray, MRI, bone scan, Doppler, or complete blood count? The next step, so if they say, what are you going to do next? Next can be X-ray. If they say, what is your best step of diagnosis or what's your definitive step? That will be MRI. So that's what we have written here. Diabetic foot, non-healing ulcer for 2 weeks, and you're concerned about osteomyelitis. Just because it's non-healing for 2 weeks doesn't mean that it will always be osteomyelitis. Remember that osteomyelitis will have their own specific feature. That means if you are suspicious of osteomyelitis, your next investigation should be X-ray. Many times X-ray will not be able to diagnose osteomyelitis, but it is still an initial investigation. And if you are still suspicious and X-ray is not conclusive, then you go for MRI or bone scan. Same patient, diabetic foot ulcer, but you have got yellow discharge from the wound, which means that you are suspicious of wound infection. Any wound infection, our next step is taking a swab from the wound and then give it a good clean, so wound toileting and good dressing, and start the patient with empirical antibiotic. All right? So that's two different scenarios that can come in the exam. Choice of antibiotic. Before we go to choice of antibiotic for diabetic foot infection, we need to know the stages of diabetic foot infection. So we divide it into mild, moderate, and severe. So mild means that patient has got an ulcer. Let's say this is the ulcer, but it is only affecting the skin and subcutaneous tissue, not quite deep. Patient doesn't have any features of systemic inflammatory response, like no fever, no nausea, vomiting, no tachycardia, and the redness around the wound, so there is usually redness around the wound, it's less than 2 centimeter. That's mild stage. So you can see the redness around the wound. So if it is less than 2 centimeter, it means it's mild. Moderate, the redness will be more than 2 centimeter around the wound. And the patient, in this case, it will look a bit more deeper. And this is the patient who will start to show abscess, osteomyelitis, those kind of things. And severe means everything that's in the moderate, plus they have got systemic response like fever, nausea, vomiting, tachycardia. So that means they are basically septic. Okay, so that's mild, moderate, and severe. If it is mild infection, we can start treatment with amoxiclav, which is amoxicillin clavulanic acid, ceflexin, flucloxacillin. So all the initial choice of antibiotic. In moderate, we go IV, so IV augmentin, cefazolin plus metronidazole. And in severe, we go for piperacillin, tazobactam, sulbactam, clavulanic acid, or ciprofloxacin. That means we go for more gram-negative organism in that case. All you need to know is just remember the name of the antibiotic. I can't help you with remembering them. You have to know. So you have to memorize these, right? So, but you know that at least how to identify which one is mild, which one is moderate, and which one is severe. Okay? So this is the choice of antibiotic. This is from Imaging Guideline or Diagnostic Imaging Pathway Australia. So if you get a patient with diabetic foot ulcer and you're suspicious of osteomyelitis, you do a plain X-ray. If X-ray suggestive of osteomyelitis, then you can treat the patient for osteomyelitis. If you want, you can do a bone biopsy, but it's not needed. You can start treatment, which will be IV antibiotics. If the X-ray not compatible with osteomyelitis, then two things you can check. One, can you see bone? If you see bone through the infection or through the wound, there is a risk of osteomyelitis. If you can't see the bone, can you touch the bone with a probe? See that this is a probe. If you insert the probe and you can touch the bone through the wound, that's also suspicious of osteomyelitis. In that case, you can start the treatment for osteomyelitis anyway. But let's say that it's not there, but you're still suspicious of osteomyelitis, then you do a MRI. If MRI not available, we do bone scan or nuclear medicine scan. All right. So this is the step-by-step investigation for any patient with diabetic foot ulcer who you can be suspicious of osteomyelitis. Cool? Yeah, amoxiclav, augmentin are same. So that's oral. So you've got amoxiclav, that's oral, and augmentin, this one is IV augmentin. A young man working came to the emergency department for big abscess under the arm. After draining the abscess, what is the investigation of choice? It's the easiest one, I think. So if you have done draining of the abscess, what will you do next? Antibiotic. This patient will need antibiotic, but before that, you always take the wound for culture and sensitivity. Once you have done that, then you can start the patient with antibiotic. Okay? I think we should be able to finish it here tonight. I guess you got a good idea about how the questions can come in exam. And you might be getting tired and overwhelmed. I don't want you to get overwhelmed on the first class. So if you guys want to ask any questions regarding the course, now you have got time. So we have got like 5 to 10 minutes. We can discuss about the course and everything about it. Yeah, the 2 weeks class is free. So you have got schedules of 2 weeks. So if you go to our First Aid AMC MCQ group on Facebook, then you should be able to find out. So go to the featured section. So every group has a featured section. And in the featured section, you will be able to, even we uploaded the last class, which is the trial class on YouTube. And we always add it in your Facebook as well. And this is all the free 2-week sessions. So your next class will be on 18th, which is the cardiology class 1. Okay. How you will get class material. So once you register for the course, we will give you access to the student portal, and with the student portal, you will get every materials. So the notes, the past recalls, you can see that we have given you random question solve. This too is our recall classes. So you'll be able to also get to know the other mentors, and those every classes, the recordings, materials are in that student portal. Yes, you will get minimum 3 class a week and sometimes 4 class, 2 hours a day. Rano Shah, yes, you're right. That's the step for open fracture with neurovascular compromise. The course enrollment, you can enroll at any time. There is no specific time that we stop the admission, but we advise that during these 2-week sessions, you should admit so that you can keep on joining the sessions, because after 2-week session, there will be no gap. We will just continue with the course. Cardiology class 1, we will do chest pain. So that will be our main focus. If anyone didn't get the access after the payment, please contact our email, or you can also contact like Arshan Ahmed, my messenger. So one of the team member will help you with that. Okay. Usually it takes few days to get the access. So if you have been waiting for 2 days, still haven't got the approval, then please contact. How can we register for the course? Good question, right? Let's have a look. So to register for the course, if you are part of First Aid AMC MCQ Facebook group, we always update about course enrollment and everything is here. So if you go through this post, you'll see that we have given the website address. Hope we have. Oh, okay. So if you go to firstaidamc.com.au, then this is our website. So just write or Google firstaidamc.com.au, and once you get into this page, go to this 5 months extensive MCQ course, click on check info, and you can read about everything that's included in the course. Once you want to register, you just click on this register now button, and it will take you to few steps. Okay. Yes, Trista Maharaj, all the classes that we are taking, these are recorded as well. So if you can't join the class as a live session, you will be able to get the recorded version in the portal. After the free classes, only thing that we will do for cardiology is ECG class. That will not be part of the free class. In the upcoming question solve, we will do June recalls. Next class is on 18th. Tatiana, because you are doing this course and the course is going to finish on 2026, this will be only valid for this year, for 2026 only. Yes, class you can add it from any device. And this course is a 5 months course. So we normally discuss that. So the course is a 5 months course, and we take like live classes 3 to 4 days a week. Class time are usually the same, like how we're doing now. You get complete theory discussion, and you will get an idea in these free sessions how we do the theory sessions. And we will also have the sample question discussions or the recall discussions. There are lots of mock tests which is available in the portal. So you get to practice a lot of lot of recalls or questions through the portal. And those are mock exams. We also have like question solve discussions, like after theory, once we finish cardiology, we will do all the cardiology questions. Same goes with any other topics that we will discuss in the course. And also monthly question solve, we will take classes. And you have got, this course has almost everything that you need to pass the exam. You really don't need anything else to pass. And a lot of students pass from this course. You can rely on us without even thinking twice. If you go into our First Aid AMC group, you will see every month so many students pass from the course. We try to add their, like, congratulate them. So if you scroll down, you will see that there is always students passing from the course. So many. Okay. So it has that standard to make sure that the students can pass this AMC MCQ within the first attempt and in the shortest possible time. If you still have any queries about the course, please go through these details. It has everything that you want to know. Okay. Therapeutic guideline, you don't really need to subscribe for it. We will discuss from it. But if you want to subscribe, then you will need to subscribe through their website. Candidate who has exam in November, so you can still do all the live classes that we are taking. And by November, most of the important theory classes will be taken again. So you are more than welcome to join those sessions. But my advice will be that if you're going for November, try to finish the theory from the past class recording. It is not a huge change from last batch, because last batch is very, very updated. Okay, because theory, what we can change for a MI management is going to be always, more or less, always the same thing. So it doesn't change a lot. Updated things we try to add a little bit every batch, but the main important topics are usually the same for theory. But again, if someone did our class back in 2024, the theory class is entirely different now, because there has been a lot of changes that we have done. But last batch is quite updated. Okay, so you can definitely finish the last batch recordings if you're going for November. Yes, Dr. Neethu or anyone, if you enroll and you go for full payment, you'll be able to get access to the last batch theory recordings and everything. Before referral to tertiary within 2 hours, it's not must to do a CT in that case. Okay, so this patient will end up getting a CT in the tertiary hospital anyway. Yes, so that's all the free classes up to 25th of August. Uh, Ram, can you send a message to me so that I can also check? I'll just see that why you haven't been approved. Just send a message in here, Arshan Ahmed. The skin question, why it was not KA. So KA will have more. See that KA has this keratinized keratin in the middle, and it will be a bit raised lump. Whereas if it is SCC, SCC will still be lump, but the central keratin will not be there. Okay, the central keratinized plug. That is how we differentiate. The picture is not really the best in here. That's why you can't see it. You can see that how the KA looks like, elevated, firm, and a central keratin plug. And you can argue that what's this? This is not keratin plug. This is just a simple keratin over there. Any SCC will have keratin on it. The recall will cover MCQs, which is the monthly MCQs. Okay? And cardiology questions, usually part of the theory class that I take. So let's say I finish cardiology, and after that I will do cardiology question. But those random MCQ sessions are just, it can be from anywhere. What do you mean daily regular classes? There is no course who takes daily regular class. We're taking like three to four classes every week, and there is no course which actually can do regular classes, means like everyday class. Okay. The PDF is part of the course, yes. So you will be able to get all the notes into the portal. When is the next course after this? Next course after this will be in end of January. No, Tanjila. So new student cannot join the question solve classes. It's only our ex-student who can join the question solve classes. And it does not include mock test. Yes, so the recordings are uploaded within 24 to 48 hours of the class in the portal, and notes are uploaded immediately. Uh, Sunila, after the free 2 week sessions, we will have a orientation class on the portal. But if you are struggling, if you are already a registered student and you are having difficulty to find out where notes and everything else is, you will be able to find out. So you'll see that there are lots of dashboard or topics, and go to where you see the recent theory classes, and also you can go to past batch theory classes. On those two, there will be notes. And under the course essential, you will also see that there is a guide to portal. So that guide to portal will have everything that you need to know about the portal. So scroll around a little bit, just like go with the portal a little bit, click on every option that you have got, you will definitely get it. It's quite simple. Please make sure that if you are joining any classes, make sure that your video is always off, because it is important and you should be careful about this. All right, guys, this is it for tonight. I still see you've got a lot of questions, but again, most of the questions are same questions. So I'm hopeful that I was able to answer most of your queries. The question solve course has been already started. So the question, we are also, if you are a past batch student and you only want to join our question solve classes, just contact us. The admission is open, and the first class of that will be 20th August. All right, that's it for tonight, guys. I hope you enjoyed the session, and we'll talk again on 18th of August. Until then, take care.